Hello everyone, my name is Mitchell Timble. I will be doing a presentation on a site for psoriasis. So it's a treatment of severe refractory plaque psoriasis. I was really drawn to this case because one, I actually suffer from a mild case of psoriasis, as well as I wanted to better understand my own disease state, as well as understand the treatment options for my patient. A little bit about our presentation. We're going to go over the etiology and pathophysiology. We're going to describe some clinical presentation, the diagnostic criteria, and review some treatment options. As far as the patient presentation, so YR is a 51-year-old Asian American male who presents to the clinic with a 25-year history of psoriasis vulgaris, presents with erythematous plaques on his trunk, his extremities, his scalp, and was diagnosed based on severity index of 25 and encompassing at least 20% of his body's surface area. Patient's currently taking Cosentyx but experiencing some complications or side effects. Next slide, we're on patient history. So we see some comorbidities as well as the medications for these comorbidities. Patient has history of congestive heart failure, atrial fibrillation, and depression, just to name some, and no social history that might contribute to the psoriasis. Looking at his overview of his treatment history for psoriasis, he has used previous topical corticosteroids, methotrexate, other non-biologic therapies. Overall, did provide some symptomatic relief, but poor disease control overall. After trying that, patient had used Humira, did show some improvement, but did develop some side effects such as bronchitis. Patient did try Stelara thereafter for about 2 years, did see some clinical responsiveness, but after 2 years, it did lose those effects. Even after doubling the dose, we saw no improvement. The patient's currently on Cosentyx, but currently requesting an alternative because of side effects such as chest congestion and bronchitis as early as April, May, and June of 2020. Considering all of our options have been exhausted, it was deemed refractory. So what are some of our options? Before we go into that, I just want to provide some more overview on psoriasis. So it is a skin disease affecting 3% of the population. It's described as a proliferation of keratinocytes and can be triggered by several external factors. As far as pathophysiology, psoriasis involves a feed-forward activation of the adaptive and innate immune system. The innate system basically produces immune cells such as interferon alpha, which stimulate the dendritic cells in the adaptive immune system, which thereby produces cytokines such as IL-12 and 23. And these are possible inhibitory factors of treatment options. And these factors actually stimulate and cause that inflammatory cascade we see often in psoriasis. And here's just a slide of that brief overview of the pathophysiology I just discussed. As far as etiology and risk factors, some comorbidities include psoriatic arthritis. About 30% of individuals who have psoriasis also develop this type of arthritis, Crohn's disease, depression. So we see that a lot of quality of life and anxiety and depression are seen in these populations, as well as metabolic syndromes, cardiovascular disease. So these are very common, especially seen in our own patient. Psoriatic risk factors, so looking at family history, a lot of it can be genetic. PSOR1 is one of the more primary factors that can contribute to psoriasis. Infection, medications, beta blockers, antidepressants can precipitate it as well. Skin trauma, social history, and obesity can also contribute to exacerbations and flare-ups. Clinical presentation, so it's typically defined by those erythematous plaques, irregular borders, and those scales, commonly found in the scalp, elbows, knees, and trunk. More than 50% of these patients are going to experience some kind of pruritus or itchiness, and potential comorbidities that we've discussed already. As far as diagnosis, typically characterized by the lesions. There's no definitive lab test or biopsy for diagnosis. It's typically based on how much body surface area it is encompassing, the severity index. So this looks at things like thickness, redness, scaling, and then quality of life. So how does it affect the daily life of our patient? All factors included. As far as classification and disease severity, we're primarily looking at severe psoriasis at this point. So the rule of 10 helps us. We're looking at severity index greater than 10, quality of life greater than 10, and encompassing body surface area more than 10. And that's just a photo representation of how much it can affect. Some of our treatment goals include minimizing the plaques and scales. We want to reduce the flare-ups and the intensity. We want making sure we're treating the comorbidities and reducing severity index at least 75 or severity index, as well as the dermatology quality of life as well. Overall, improving the quality of life of our patient. Next slide. This kind of gives you a little bit of an overview of the treatment goals or treatment options for psoriasis. I believe this is by the American Academy of Dermatology. We can see that our patient already used several of these options: topical corticosteroids, several biologics, other non-biologics. So we've really exhausted and looked at a lot of our treatment options that have been used. Back to our patient treatment history. So we saw that the patient has already used TNF-alpha inhibitor in Humira, a IL-12/23 inhibitor in Stelara, as well as an IL-17A in Cosentyx. So what else is left? So another option is a recently new psoriatic medication called Skyrizi, which is a IL-23 antagonist. So it is primarily indicated for moderate to severe psoriasis for individuals who have failed other systemic therapy or phototherapy. It's typically dosed at 150 milligrams sub-Q at 0 and 4, followed by every 12 weeks. As far as adverse effects, risk of infection is fairly common. A lot of patients who were on clinical trials experience a lot of upper respiratory tract infections or tinea. So we want to make sure we're monitoring for CBC with a lot of these other differential diagnoses of infections such as TB, hepatitis C, hepatitis B virus, and avoiding live vaccines. So what do the clinical studies? So I just wanted to touch over a few studies that emphasize the use of Skyrizi. So the first was Ultima 1 and Ultima 2. This was a randomized multi-site double-blinded control trial. It compared Skyrizi with Stelara, and what we saw was that as early as week 16, we saw improvement in patient-reported outcomes in quality of life, psoriasis symptoms, and especially actually anxiety and depression. So we saw that as early as 16 weeks, we saw improvement in those stats and anxiety and depression also as early as week 16. Overall, both biologics saw no difference by week 52. They were both effective. The next trial I wanted to kind of go over was a ENHANCE trial. So this was the two-part phase 3 randomized trial comparing Skyrizi to placebo. This trial saw significant improvement at week 16 compared to placebo, especially in severity index. So saw improvement in skin thickness and scaling, and it was efficacious even after re-randomization. So really showing that there was a lot of improvement compared to a lot of placebos and other biologic options. Overall, both of these studies showed, as far as side effects or possible problems, it was mostly risk of infection, tinea, upper respiratory. So very common in a lot of the biologics as well. So as far as our patient case recommendation based on the studies, he fits a lot of the population after failing more than 3 biologics and having a severe or moderate case of psoriasis. Our plan is to provide something for flare-ups, so a topical corticosteroid of fluocinolone, as well as initiating Skyrizi. As far as recommendation on pharmacological options, we're going to give moisturizer, skin protectant, and fragrance-free cleansers as recommendations, and then we will reassess in 8 weeks. When the patient came back, we saw that the residual redness actually had cleared up. Some of those raised lesions have flattened, and overall we saw decrease in inflammation and scaling. And that's it for my presentation. Thank you for listening. Can't wait to meet everyone in person at the interview. Thank you.